Hey guys, welcome back to my channel, The ENT Resident. Today I'll be discussing about nasopharyngeal carcinoma. So I'll break this into two videos. In part 1, we'll be talking about what is nasopharyngeal carcinoma, what is the age and the gender where we see it more commonly, what is the etiology behind it, what is the pathology, what is the histological features, how do we classify it, and what are the clinical features that we see in this. And in part 2, I'll be talking about the management of nasopharyngeal carcinoma, meaning investigations and treatment. You can also now purchase my notes. I have added links in the description. Okay, so let's get started. Now, what is nasopharyngeal carcinoma? So, this is a malignant epithelial neoplasm which is involving the nasopharynx. So, this is a malignant neoplasm which involves the epithelial lining of the nasopharynx, and this is a non lymphatomatous squamous cell carcinoma. Now, this is a multifactorial disease. So, we do not know exactly what is the exact cause behind nasopharyngeal carcinoma. There are multiple factors in play which all work together to cause this. There's genetic factors, there's some environmental factors, and there's also viral factors. And the virus involved with nasopharyngeal carcinoma is the Epstein-Barr virus. We'll talk about more about the etiology in a little bit. Coming to age group, this is one of those carcinoma. This is actually a very important MCQ question, which has a bimodal distribution in age. So it has a small peak around 15 to 25 years. That is the first peak, and second peak comes in around 50 to 55 years. So this is a bimodal age presentation. Usually, the age at which it occurs is in between the fifth and the seventh decade. And after this, the incidence of it starts decreasing as the age increases. So we have a bimodal disease, first peak at 15 to 25 years and second peak at 50 to 55 years. Next, coming to gender, it is more male dominant disease with a ratio of 3 is to 1. And coming to geographically, highest incidence is seen in southern China, Taiwan, and even in Southeast Asia. It is comparatively uncommon in India. About 0.4% of all cancers is nasopharyngeal carcinoma in India. So that's about the basics of nasopharyngeal carcinoma. Now we'll talk about the etiology of it. So, as I mentioned, we do not know what is the exact sequence of events that happen over here, but there is an interplay of multiple factors like genetic factors, viral factors, and environmental factors involved. Let's talk about each one of these factors now. Coming to genetic factors, why do we think that there's a genetic factor involved here? That's because we see a wide variation in incidence all across the world, and that implies probably there's some kind of genetic susceptibility to this cancer. And we have seen in about 10% patients, there's a familial clustering of cases. And another evidence behind genetic factors is that, say, a particular group of people, they are more genetically inclined to to develop nasopharyngeal carcinoma. Even they might, after migrating from these high endemic areas to low endemic areas, those inhabitants, they have retained the same high incidence of this disease. So this all of these reasons are why we suspect that there's probably some genetic factor involved in the causation of this cancer. Now, coming to HLA association under this, there are some HLA subtypes which have an increased risk of this cancer and some HLA subtypes which have a decreased risk. So let's know each one of them. So the ones with increased risk of nasopharyngeal carcinoma are HLA-A2, B14, and B46. These are the three with increased risk. And the three with this decreased risk is A11, B13, and B22. So these are the HLA associations that you have to remember in relation to nasopharyngeal carcinoma. Now, what happens with this association? So the three increased risk ones, the A2, B14, and B46, what happens here is these subtypes usually they have an impaired immune response to the Epstein-Barr virus. What happens is if you get infected by this virus, in these individuals who have these HLA subtypes, the clearance of virus from the epithelium is also lesser. So, because of this impaired immune response to the virus as well as decreased clearance of the virus, what happens is a latent Epstein-Barr virus infection in the epithelium leads to the development of some pre-malignant changes in the epithelium, and eventually this advances to form an invasive cancer. So that is how the HLA subtypes are important. So these three subtypes, the HLA-A2, B14, and B46, they have an increased risk. Why? Because of an impaired immune response to the Epstein-Barr virus and decreased clearance of this virus once you get infected. So, any latent infection in these individuals will actually lead to pre-malignant changes and then eventually leading to invasive cancer. Next, coming to environmental factors, there are certain associations over here. It has been seen that people who consume more salted fish or other preserved food, these preserved food, the preservatives in them, they also contain a very high nitrosamine content, and that has been seen to be involved with an increased risk of developing this carcinoma. So basically, preserved food and salted fish. Second environmental factor is smoking. So it has been seen that smoking really increases the risk of this cancer in both types of population, even in population where we see a high incidence of this cancer and even in population where we see a lower incidence. And this risk of increased risk associated with smoking increases further, especially in the well differentiated type. So that is our third environmental factor involved. Second. Coming to the third environmental factor, it has been seen that burning of incense or wood is also associated with an increased risk because they release polycyclic hydrocarbons, which is a carcinogenic element. And last environmental factor is if you are deficient in vitamin C, they have also been seen to have an increased risk to this. Why? Because vitamin C actually has a mechanism where it blocks nitrosification of amines. By blocking nitrosification of amines, it actually has a protective effect on the body. Now, if you are deficient in vitamin C, this function is not possible by your body, and that is why you have an increased risk to developing the carcinoma. So these are our four environmental factors that has been associated. One is preserved food, which are high in nitrosamine content. Second is smoking. Third is burning of incense or wood because they release polycyclic hydrocarbons. And fourth is a vitamin C deficient diet. Lastly, coming to the third most important part in the causation of this disease is the virus, which is Epstein-Barr virus. So, Epstein Barr virus, how did we find out that Epstein Barr virus could be related to this? So, all the NPC patients, NPC meaning nasopharyngeal carcinoma patients, they have elevated antibodies against Epstein Barr virus. And Epstein Barr virus has also been isolated in the poorly differentiated and the undifferentiated types of nasopharyngeal carcinoma. We'll talk about these types just in a little bit. And we have also found the Epstein Barr virus DNA sequence in the nucleus of these carcinoma cells. So we do not know what is the exact role that this virus plays in the causation of this disease. As I mentioned before, the HLA subtypes with an increased risk, they have genetic susceptibility to developing a latent Epstein virus infection. And this, combined with other environmental and dietary factors, what it does is all of these risk factors combined, interplaying together, it converts the normal nasopharyngeal epithelium into a pre-malignant stage. And this, once it converts into the pre-malignant stage, this supports the Epstein-Barr virus genome in this new nasopharyngeal epithelium, which has become pre-malignant. And then this Epstein-Barr virus genome gets incorporated into the epithelium and eventually turns malignant. So this is all about the etiology over here. We do not know what is the exact cause over here, but there's an interplay of a viral factor, which is Epstein-Barr virus, certain environmental factors, and certain genetic factors, which predisposed to certain individuals developing nasopharyngeal carcinoma. Next, let's talk about the pathology. Before we go into the histology, we'll talk about what are the types, what is the classification of nasopharyngeal carcinoma. So originally, WHO had classified these epithelial malignancy that arise from the nasopharynx into three subtypes. These three subtypes were type 1, type 2, and type 3. So type 1 was well differentiated keratinizing, type 2 was non keratinizing, and type 3 was undifferentiated carcinoma. But this has now been revised into two subtypes. So now it has been classified into keratinizing and non-keratinizing carcinoma. And non-keratinizing carcinoma can be further divided into differentiated type and undifferentiated type. So we find this is a squamous cell carcinoma. So we find various grade in its differentiation, and also a lot of other variants can arise from it, like transitional cell carcinoma or lymphoepithelioma. And these various grades actually is the most common type that we see over here in about 85% of the cases of nasopharyngeal carcinoma. And in 10% cases, we see lymphomas, and in 5% cases, it can be other types like rhabdomyosarcoma, malignant mixed salivary tumor, or malignant chordoma. So that's about the different types and what is the classification of nasopharyngeal carcinoma by WHO. Now let's talk about the histology of this disease. So first, if we look at the macroscopy of this, we can actually classify into three different types of growth that we can see in a nasopharyngeal carcinoma. So there can be an ulcerative growth, there can be an infiltrative growth, and we can also see an exophytic growth. So this is the macroscopy based classification. So let's discuss each one of them. So the ulcerative growth, we usually see it arising either from the posterior wall of the nasopharynx or from the fossa of Rosenmuller. So fossa of Rosenmuller is actually the most common site from where we see nasopharyngeal carcinoma originating from. So, and then histologically, the ulcerative growths are usually well differentiated and they tend to destroy and enlarge the foramens in the base of skull and eventually spread to the middle cranial fossa. And this type, the most common symptom in this type is bleeding from the nose. So, this is about the ulcerative growths. The ones which are infiltrative, they are seen to be arising from around the eustachian tube opening in the lateral wall of the nasopharynx. And these, they have a very different appearance compared to the ulcerative type. This type has grape-like polypoidal appearance, and sometimes they can even have ulceration on its surface. And these tumors can either spread anteriorly to the maxilopharyngeal space and involve the fifth cranial nerve, or it can spread down to involve the soft palate, or it can even spread superiorly into the orbit via the inferior orbital fissure. So the infiltrative type this type of growth actually infiltrates submucosally. That's about the infiltrative type. The third type is the exophytic type. Usually they look hemispherical, non-ulcerated, pedunculated smooth tumor, and the common site of origin in this type is the roof of the nasopharynx. And the most common symptom we see here is obstructive nasal symptoms, and this type also pushes the soft palate downwards. So you can see that all the three different types, they have different usual sites of origin, and they usually have a different looking appearance and a different symptom which is more commonly seen. Next, looking at the microscopy of this, we have the Broder's grading over here, which divides it into grade 1 to 4. Now, grade 1 is well differentiated, where the cells show keratinization and very obvious differentiation. Only less than 25% cells lack differentiation, meaning less than 25% cells are undifferentiated. Then grade 2 is moderately differentiated, where about 25 to 49% cells are undifferentiated. Then grade 3 is poorly differentiated, where 50 to 74% of cells are undifferentiated. And lastly, grade 4, which is anaplastic type or the undifferentiated type, where more than 75% are undifferentiated cells with marked anaplasia and mitotic figures. So that is the microscopical grading of nasopharyngeal carcinoma, which is known as the Broder's grading. Next, let's talk about where does this originate from, and we'll talk about the spread of this tumor in different directions, because this is actually a very important long question that you face in your theory exams, and even it is important in your vivas as well. So, coming to site of origin, as I mentioned, the most common site of origin is the fossa of Rosenmuller, and this is a MCQ question that you need to know. Other than this, it can originate from the posterior wall or the superior wall of the nasopharynx, and sometimes it can even have origin from multiple walls of the nasopharynx. Coming to spread. Now, if we look at this image over here, this is the lateral wall of the nasopharynx. We have the choana over here. This is the eustachian tube opening. This is the eustachian tube opening, and right behind that lies posterior superior to the eustachian tube opening is the fossa of Rosenmuller. So this is our fossa of Rosenmuller. That is the most common site of origin for nasopharyngeal carcinoma. So when we talk about spread, we can divide the spread of nasopharyngeal carcinoma into local spread, lymphatic spread, and hematogenous spread. So first we'll divide local spread. That this local spread part is actually there's a lot to understand because it can spread in all the different directions. So first of all, first let's talk about upward spread. So this is the region of fossa of Rosenmuller. So this upward spread is actually the most frequent passage for the intracranial spread of this tumor. So, if you look over here, this is the base of skull right over here, and the tumor is developing here. So, when it spreads upwards, it is going to involve the intracranial cavity. So this infiltration over here, this can either happen by infiltrating the bones of the base of the skull, or it can even extend through all the different foramens that are present in the base of the skull. We know that there's a lot of different foramens like foramen spinosum, foramen lacerum, etc. over there. So this tumor can spread to all those basal foramens, or they can spread by infiltrating the bone. So, amongst the foramens, the most common foramen that it spreads through is the foramen lacerum, because this foramen lacerum lies very close to the fossa of Rosenmuller. This frequent passage that we are seeing over here, that for the intracranial spread of tumor, this passage is actually known as the Linconi's highway. And when invasion occurs via this route, without invading the surrounding sphenoid, petrous, or the occiput bones, this is referred to as the petrosphenoid route or crossway. Now, what happens once this upward spread happens when the tumor infiltrates and reaches the cranial cavity? What are the different structures that it can involve over here? So, first of all, it will involve all the cranial nerves that are passing through this basal foramen. So one of the when the foramen lacerum and the cavernous sinus gets involved, there's a lot of symptoms that you would be seeing over here. So the third, fourth, sixth, and V1, V2 divisions of the trigeminal nerve and trigeminal ganglion and sympathetic carotid plexus, all of these gets involved when the cavernous sinus is involved. So that is one presentation. Second presentation is it can extend once it has reached the cranial cavity, it can actually extend forward along the anterior floor of the middle cranial fossa. When it does that, it can involve the optic nerve, the orbit, and even the structures in the anterior cranial fossa. Posterior fossa extension is actually very rare over here because dura mater is very resistant. But in later, very advanced stages, we can see destruction of the mesencephalon, cerebral peduncles, and temporal lobe. Lastly, if it involves the basi-occiput, basi-sphenoid, the petrous temporal, and the sella turcica, it can reach the optic chiasma. So, optic chiasma lies in this region. Once it reaches the optic chiasma, it can extend towards the orbit through the superior orbital fissure and lead to development of proptosis. So, you can see as it spreads superiorly, through the either infiltrating the bone or through the basal foramina, and it reaches the intracranial cavity, which is known as this pathway being known as Linconi's pathway. It can involve everything in the cranial cavity. It can have multiple nerve involvement. Next, we'll talk about the most common spread, which is lateral spread. So, if you think about it, the fossa of Rosenmuller, which lies in the lateral wall of the nasopharynx, what lies lateral to it? So, the spread over here is it spreads posterolaterally through the sinus of Morgagni, and it ends up reaching the parapharyngeal space. This route is known as the retroparotidian route. So once it has reached the parapharyngeal space, it will present just like any other parapharyngeal space tumor presents like. So if it involves the pre-styloid compartment most commonly, from there it will involve the base of the skull, the foramen ovale, foramen spinosum, greater wing of sphenoid, temporal fossa, parotid gland posterolaterally, and submandibular gland at the floor of this compartment. And if it extends posteriorly from here, it can spread to the jugular foramen. So, this lateral spread is the most common direction of spread that we see in case of nasopharyngeal carcinoma. Next, think about anteriorly. So, a nasopharynx lies posterior to the nasal cavity and the paranasal sinuses. So, anteriorly, if it spreads, it will involve the nasal cavity and the paranasal sinus. And we also have spinopalatine foramen. So, via the spinopalatine foramen, it will reach the pterygopalatine fossa. And we know that pterygopalatine fossa is connected to the infratemporal fossa. So, from there, it will spread to infratemporal fossa. And once it spreads to the infratemporal fossa, it will involve all the pterygoid muscles and the parotid. So, this is the anterior spread of nasopharyngeal carcinoma. Next is inferior spread. Now, if you think about inferiorly, what do we have inferiorly? So, below the nasopharynx lies the oropharynx, and we have the soft palate over there, the lateral pharyngeal wall. So, inferiorly, it can involve the fosses or the pillars. It will involve the soft palate. It will involve the lateral pharyngeal wall, oropharynx, and if it goes even further, it will reach the laryngopharynx. And lastly is the posterior spread. Posterior spread would involve the retropharyngeal compartment, which lies behind the pharynx, and prevertebral fascia and muscles, and the arch of Atlas. So, that is all the spread that happens in different directions over here, and each of it would lead to different symptoms. Another thing that I missed talking about is the eustachian tube opening that lies just in front of the fossa of Rosenmuller. So, if the eustachian tube opening gets blocked, it will lead to otologic symptoms. You'll have symptoms of serous otitis media. So, next we'll talk about the lymphatic spread and the hematogenous spread. So, coming to lymphatic spread, the lymph node that gets involved, the earliest lymph node to get involved. This is a very important MCQ question. Earliest lymph node to get involved in nasopharyngeal carcinoma is the retropharyngeal lymph node, also known as the node of Rouvier. So, this is the earliest and the most frequent to get involved because of its proximity. But however, this is not the one which is noticed earlier because it lies in an area which is inaccessible. Other than this, the most common group to be involved is the upper jugular nodes. Most commonly out of this would be the level 2 lymph nodes involved over here. There can be a diffuse and bilateral involvement, and higher in percentage of involvement has been seen in spinal accessory chain, upper mid and lower jugular, supraclavicular, and glands beyond the thoracic inlet. So this is about the lymphatic spread. And the last four cranial nerves which pass through the jugular foramen, they can get involved because due to the compression by this retropharyngeal node, which lies very close to the jugular foramen. Sorry, the not the retropharyngeal node. This is the node of Krauss. When this node gets involved, it can compress on the cranial nerves which is passing through the jugular foramen and lead to the development of jugular foramen syndrome. So, from this, I also wanted to say that there's a lot of different syndromes that are associated with nasopharyngeal carcinoma, and that's a very big question that you have to answer. And these foramens depend on the different nerves involvement that happens once the base of skull is involved. So, this is about the lymphatic spread. So the last type of spread is the hematogenous spread, which is the rarest spread over here amongst local, lymphatic, and hematogenous. If it does happen, it will spread to bone, liver, and lungs. And within the bone, what is the most common bone to be involved? It will usually involve the spine, shoulder, pelvis, and skull. And the spread to the spine occurs through this Batson's prevertebral venous plexus. So, this is about the spread of nasopharyngeal carcinoma, which in itself is a very long question that you need to answer. Now, let's talk about the clinical features. What are the symptoms and signs that a nasopharyngeal carcinoma patient will present to you with? So, symptoms are actually very varied. The most common symptom that we see is involving the cervical lymph nodes, but other than that, we'll also be seeing otologic symptoms involving the ear, we'll see ophthalmic symptoms, we'll see nasal symptoms, and we'll even see neurological symptoms. So let's talk about each one of them. Starting with the most common presentation of nasopharyngeal carcinoma, which is cervical lymphadenopathy. This is the most common presentation seen in about 60 to 80% cases. And the most frequently involved lymph nodes over here is the level 2, which is the upper jugular nodes, and next is the upper level 5, which is in the area of the apex of the posterior triangle. So, this is the most common lymph node involved. However, the first node to be involved is the lymph node of Rouvier, which is also known as the retropharyngeal lymph node. And the first palpable lymph node is the jugular digastric lymph node. So these are some very important MCQ questions right over here. The most common presentation of nasopharyngeal carcinoma is cervical lymphadenopathy in about 60 to 80% cases. Most common lymph node to be involved is the upper jugular, which is level 2 nodes. First node to be involved is the node of Rouvier, and first palpable lymph node is the jugular digastric lymph. Now, as this lymphatic spread occurs here, it actually occurs in a very orderly fashion from superior to inferior direction, and skip metastasis is rare in this case. So, the another one of the presentation, sometimes a patient of nasopharyngeal carcinoma can actually come to you with just metastatic lymph node in the neck with an unknown primary. Nasopharyngeal carcinoma would be one of the differential diagnoses in these cases. So you may not see nasal symptoms or any obstruction symptoms anywhere or any neurological symptoms, but the only presentation is a cervical lymph node involvement in metastatic lymph node, and you do not know what is the primary, where does it lie. So that is one of the presentations. Next, let's move on to the next type of presentation, which is the nasal presentations, nasal symptoms. We see nasal symptoms in about 50% cases. And the most common nasal symptom that we see is a blood-stained nasal discharge or post-nasal drip. Patient will also come to you with nasal obstruction. Usually, the nasal obstruction is unilateral on the side of the tumor in the beginning. But as the mass starts growing bigger and it extends to fill up the complete nasopharyngeal area, and it extends to the other side of it, then you also complain of bilateral nasal obstruction, and this will be associated with some epistaxis. Eventually, it will lead to complete and progressive nasal obstruction. And another nasal symptom here is cacosmia. Cacosmia is when you get a smell of blood, and this is occurring because of the bleeding occurring from the tumor, because bleeding is also one of the symptoms over here. So, this is about the nasal symptoms. Next, coming to otologic symptoms. So, we know that the eustachian tube and the fossa of Rosenmuller are very closely related. Fossa of Rosenmuller lies posterior superior to the eustachian tube opening the orifice of the eustachian tube, which opens in the lateral wall of the nasopharynx. So, in about 30 to 40% cases, we see symptoms involving the ear. Why does this happen? This can happen because of two reasons. Either the because of the tumor bulk, or because of invasion by the tumor, there is eustachian tube dysfunction. Now, once there is eustachian tube dysfunction, it will lead to symptoms similar to that of otitis media with effusion. You'll have some blocked sensation in the ear. You'll also have some amount of hearing loss, conductive hearing loss on the side. The patient may also complain tinnitus. So maybe sometimes the patient presents to you with an unresolved otitis media with effusion. No matter whatever medications you're trying, medically you're not being able to treat the disease. So if a patient comes to you with unresolving serious otitis media, in that case, just examining the ear does not do it. You have to examine the complete ENT region. So sometimes the cause could be right lying in the nasopharynx, and you could have missed it because you just examined the ear and prescribed some medical treatment to the patient. So, this is all the otological symptoms. And lastly, you can also have pain in the ear. This happens because pain is a later symptom in very advanced cases of nasopharyngeal carcinoma. This can happen because of skull base erosion and referred pain because of the involvement of the third division of the trigeminal nerve. Next, coming to ophthalmic symptoms, if there is third, fourth, and sixth cranial nerve involvement, it will lead to diplopia. You can have epiphora, proptosis if the orbit gets involved, ptosis as a part of Horner syndrome, or if there is a third nerve palsy. Then there could be loss of corneal reflex where fifth nerve gets involved. If the third, fourth, and sixth nerve gets involved, it will also impair the extraocular muscle movement. Next, other than that, there can be anophthalmos or optic nerve involvement, which is very rare. And lastly, xerophthalmia because of involvement of the greater petrosal nerve at foramen lacerum. Lastly, we have neurological symptoms. So, neurological symptoms, whenever they are present, it only indicates the presence of an advanced stage of the disease. And the most common neurological symptoms that we see here is headache. This headache is usually localized to the vertex or the occiput region. And why does it happen? It occurs because of erosion of the base of skull and subsequent sepsis. So, neurological symptoms will develop when we have different cranial nerve palsies. If there is an upward spread happening in this, the multiple cranial nerves can get involved, like 2, 3, 4, 5, 6, 7, 9, 10, 11. So, 9, 10, 11 usually they get involved together. The most frequent one to be involved is the fourth nerve, sixth nerve, and ninth and 10th. If the fifth nerve, the trigeminal nerve, gets involved, the patient will complain of facial pain and facial paresthesia in the mid region because of the invasion of the second division of the trigeminal nerve. If the ninth and 10th nerve gets involved, the soft palate movement will be lost. We'll see Trotter's triad. If the 9th, 10th, and 11th gets involved, we'll see jugular foramen syndrome. If the orbital apex gets involved, we'll see ophthalmoplegia, reduced vision, and proptosis. Trismus will be seen when tumor has directly invaded the pterygoid muscles. When does this happen? When there is a lateral spread where it involves where it reaches the infratemporal fossa and hence involves the pterygoid muscle. And lastly, we can also see Horner syndrome, which is quite uncommon actually. So, as you can see, there's multiple cranial nerve involvement which can happen in an advanced stage of this disease. Then, other than this, the general features like weight loss, loss of appetite will happen like any other malignancy. And I've also spoken about distant metastasis before. So, the common sites are liver, lung, bone, and brain being the rarer site. The most common site amongst the bone is the thoracoabdominal spine. And last one is a paraneoplastic syndrome. Sometimes a patient of nasopharyngeal carcinoma can present to you with dermatomyositis. They can actually either develop concurrently with the nasopharyngeal carcinoma or it can even develop later after the diagnosis has been made. So that's all about the symptoms. Now, if we had to look in terms of what is the most common symptom and what is the least common one, so the presenting symptoms in order of frequency, the most common presentation is a cervical lymphadenopathy, where the most common lymph node, let's revise this again, the most common lymph node to be involved is level 2. The first lymph node to be involved is the Rouvier lymph node, and the first lymph node which is palpable is the jugulo-digastric lymph node. Then we have hearing loss, nasal obstruction, epistaxis, cranial nerve palsies, the most common being the sixth cranial nerve, headache, earache, neck pain, and weight loss. So these are all the presenting features that you will be seeing. Now moving on to discussing the signs. Looking to the cervical region first, as I have mentioned before, the jugular lymph nodes get involved. Level 2, 3, 4A, 5 are enlarged, and this is usually the first clinical presentation. There's something area which is known as a hose triangle. If you look at this image over here, hose triangle is also known as the supraclavicular fossa. This is bounded by the two ends of the clavicle, as you can see by the points A and B, and the point C where the neck meets the shoulder. This point over here. This triangle forms the supraclavicular fossa or the hose triangle. This triangle is a very important site for metastatic neck nodes from nasopharyngeal carcinoma. Next, if you look at this mass over here, this is what a nasopharyngeal mass looks like. On nasal, when you perform endoscopy of the nose, you'll find that there is a reddish friable mass in the nose which bleeds on touch. This is a very, very vascular tumor. So this tumor on touch will bleed, and it is a very friable mass. So sometimes if the mass has advanced a lot, you'll see the nasopharyngeal mass extending right to the nasal cavity. And when you perform endoscopy, you may also see that it has blocked the eustachian tube. So the patient will also have features which are suggestive of otitis media with effusion. The patient will have a blocked sensation in the ear. They may also complain of tinnitus and some degree of conductive hearing loss. When you examine the pharyngeal area, sometimes you can see palatal swelling if the tumor bulk has increased in the advanced stages. And when you perform a posterior rhinoscopy, which is very, very important over here, it will reveal either an ulcerative, infiltrative, or an exophytic growth in the nasopharynx. And in advanced cases, it can even include the oropharynx and further into the laryngopharynx. On examination of the eye, we can find ptosis, proptosis, reduced vision, and ophthalmoplegia. And as I've mentioned before, neurologically, intracranially involved nerves are the fifth, sixth, third, fourth, seventh, and the second nerve. And extracranially involved cranial nerves would be the 9, 10, 11, 12 nerves. Loss of corneal reflex would be the first sign of intracranial invasion, and we can also see Horner syndrome, but that is comparatively rarer. Last part is this for today is this different syndromes associated with nasopharyngeal carcinoma. So we can see the Grady-Negos syndrome when the fifth and sixth nerve gets involved with petrositis. Syndrome of Foy, where cranial nerve 3, 4, 5, 6 gets involved. Jacob's triad, where nerve 2 to 6 gets involved. Syndrome of Aviles, where cranial nerve 10th is involved. Syndrome of Schmidt, where 10th and 11th gets involved. Syndrome of Hugling-Jackson, where cranial nerve 10, 11, and 12 gets involved. Wernicke syndrome, which is a syndrome of jugular foramen, where 9, 10, 11 is involved. Collect-Sicard syndrome, where we see a 9, 10, 11, and 12 involvement. Willerud syndrome, where 9, 10, 11, 12, along with sympathetic chain gets involved. Garcin syndrome, where there's an unilateral paralysis of all cranial nerves. Sympathetic nerve syndrome of Tapia, where 10th and 12th gets involved. And lastly, a very important MCQ question is what is Trotter's triad? So this is one of those very big questions. Whenever Trotter's triad is seen, you only remember nasopharyngeal carcinoma. So what is this triad? We have ipsilateral neuralgia, palatal paralysis, and deafness. So conductive deafness is happening because of eustachian tube block. I have mentioned this already. Ipsilateral neuralgia is usually temporoparietal neuralgia, which happens because of trigeminal nerve involvement, and paralysis, which of the palate, which happens because of the vagus nerve involvement. So that's all about today's class. In my next class, I'll be discussing about the management of nasopharyngeal carcinoma. If you have any further questions on this, please note them down in the comment section and I'll get back to you.